Dr. Ara Duke-Majan here with my team, and we are going to be performing Duke laser disc repair endoscopic transforaminal annular debridement on our patient, who is here with really 3 symptomatic discs in his back. They are all disc herniations that are causing back pain and leg pain on the left side. So I'm going to talk to my patient for a moment. Sir, it's Dr. Duke. You okay? We're going to get started. In a moment, we're going to put you to sleep. When you sleep, you'll be asleep for the rest of the surgery, and then you'll wake up, we'll be done, okay? That's my hand touching your back, just so you know, okay? And you know what? My cable is is stuck on my gown, and it's pulling on my mic. I should have attached it, but I didn't think I needed to. Yeah, that's fine. Thank you. All right, so we're going to get started. You're awake for the first 10 minutes while I get everything in position. And once I've got everything where I need it, I'm going to put you to sleep, okay? All right, so at this point, I want to make sure you're comfortable where you're laying. Everything padded up good, comfy? All right. Then the next thing I'm going to do is I'm going to put some numbing medicine in. You're going to feel a little pinch and a burn on your back. That's normal, okay? Don't get upset. If you have any pain during the surgery, what I'd like you to do is just let me know by saying, ouch. Now, are you a Marine? All right. I know you're going to be tough, but let me know if you feel pain, okay? There's no reason for you to suffer. Everybody responds differently to the surgery, so our goal is to try to keep you as comfortable as possible. That's the numbing medicine. All right. I told everybody you're a Marine. They don't know who you are. All they can see is a back, okay? If you have any questions, feel free to ask me. Otherwise, I'll be talking to different people. I'll be talking to my team, the audience, the anesthesiologist, and you. So really 4 parties, okay? All right. Now you're going to hear me say things like shot. What I'm asking for is just a picture. All right, just so you know. Num num. Let me know if it hurts. Just say ouch, okay? Oh, thank you. 90% back pain. So our patient, everybody's a little different that comes in with a herniated disc that's symptomatic, causing pain, but this patient has about 90% of their back pain 90% of their symptoms is back pain. The other 10% is left leg. Let's get a shot. Okay. That's pretty good, actually. Let's go lateral, please. So it's an interesting case because their L5S1 is not symptomatic, in my opinion. I don't have 100% evidence of that, but based on the localization of the pain, it does not appear to be symptomatic. Let's look a little bit south. I want to make sure I'm looking at the MRI, and I want to look at L5S1. L5S1 is a normal size disc, meaning that it's normal from front to back. It's definitely compressed down, but there's no big herniation or anything that I can see. The annular tears with the herniations are at 2, 3, 3, 4, 4, 5, but not at 5, 1. There's also a pseudodisc at S1 and S2, and I want to make sure I can see that. I see that on the X-ray, and I see the L5S1 disc. So the needle itself is right in the middle pretty much at L3-4. So I want to do the 3-4 disc, the 2-3, and the 4-5. All right, so to do the 3-4, I need a little more wag. Can you do that for me? Might as well go for that one first. So sacrum 5, 4, 3. All right, so our fluoro needs to go to the ground all the way every time, which it probably is. and then the table needs to come up because you got way too much overexposure. That's good. And we need that light off. It's right in my eye. Or move it. Yeah, that's fine. Okay, now let's see here. I still don't feel like we've wagged enough. Maybe go a little bit more. We want to get those. Are you looking at the x-ray? Yes, yeah, take a look at that x-ray and you can see the end plates are not quite lined up. So let's try a little more wag. So the first step of the surgery is to, that's perfect, is to get into the disc that we need to fix. So that's what I'm going to start doing. Shot. And shot. 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 Any pain? No. Shot. I feel it going through the herniation. There's a big tear there. It really went in. You can actually feel it with, with the needle. So the only thing I'm not happy about is the fact that I can't see the sacrum. But, well, I know where we are. Let's go ahead and wag it because we're not going to be able to see the sacrum and do 2-3. So let's go ahead and just get 2-3 lined up, get that in, and then we'll come back down to 4-5. And you're pulsing, right? So there's so much to talk about with each of these surgeries. They're still not lined up on the end plates. You're close. You need about another 1 degree. That's why we allow the audience to ask questions, but when the audience is not asking questions, that's perfect. When the audience is not asking questions, generally I'll just pick a topic and start talking about it. And sometimes we recycle these topics, but today we'll talk a little bit about radiation. Blood pressure's good, yeah. So the way that we navigate in spine surgery is by using a machine called an X-ray machine. And X-rays are a type of electromagnetic radiation. They're basically a wave of energy that passes invisibly through the air. And radiation in very low doses is used in medicine, but it's also used in higher doses in medicine to treat tumors and things like that. But we use a very low dose radiation system. When you go to the airport, you go through security. A lot of the security is done with X-rays. They're doing a scanner, basically. So you're getting electromagnetic radiation at the airport. You get a little bit in the operating rooms. But the goal of the surgeon is to reduce or minimize. The goal should be to reduce or minimize the amount of radiation the patients are getting. And so that's one of our goals here at Duke Spine. That is not, unfortunately, not a goal shared with all spine surgeons. Okay, and the reason I say that is I've worked with many, many spine surgeons in the operating room with radiation, and it's amazing to me how they're not really aware or cognizant, or I don't know what the right word is, caring about the radiation exposure to themselves and the patient. Shot. You'd be amazed how many people don't respect the radiation. And I say that because I think everyone should be concerned about it that works with it, particularly in healthcare. Shot. You want to try to reduce the amount of radiation exposure your patient gets. Okay? Just like you want to reduce blood loss. So anything you can do to mitigate that exposure, to reduce it, is good. So let's talk about shot. Let's talk about some of the strategies we use here at Duke Spine to reduce the risk of radiation exposure. One of them is to use the X-ray machine to push the button as few times as possible. All right, shot. So having a good understanding of the anatomy helped, so we're not lost during the surgery trying to figure out where we are. Another thing we do is we use a burst mode where I'm actually delivering radiation at lower doses, because it's not a constant beam of radiation going to the patient. Shot. Is that uncomfortable? All right. Where do you feel it, Shot? Huh? Shot. In the leg. How far down your leg? Shot. Okay. Shot. 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 Let's get an AP. I think I'm more medial than I want to be. So we use the, transverse process, and more lateral. Let's go back to a lateral view. I may need to do a second incision just to get the trajectory right. I may need. I don't know for sure that I'm going to do it. All right, shot. Shot. So give me a second, folks. I'm going to focus on what I'm doing for just a minute here, and then I'll be able to talk to you again. Shot. 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 Let's go AP. We use the X-ray machine to navigate through the spine, because the spine is boned and you can actually see pretty well on the X-ray machine, so I'm a little bit too low. Let's go back to a lateral view, but at least I'm closer to the midline, closer to where I need to be. That's it there. All right, let me see if I can adjust my approach. Shot. Shot. Where do you feel that, Shot? Shot. Shot. No. Shot. 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 Uh-huh. Mm-hmm. Shot. Shot. Now. Shot. Shot. Again. Again. Let's just get an AP, see where we are. So the process of using the X-ray machine to get to where we need to go in the spine is called navigation. Wow, I'm too far lateral. Interesting. I'm probably going to have to make another incision. Let me just see if I can access it up here.
You have a question?
Sure, I'll take the question.
One reviewer says, I have a herniated disc, but the location of the pain shifts depending on my daily pattern of movement. Why is that?
I heard the first part. I'm sorry, Sean, if you could repeat the question.
So the patient has a herniated disc, but she says that the pain or the location of the pain changes on her daily pattern of movement. Why would that be?
Well, the question is, I have a herniated disc, but the pain changes depending on my movement, my pattern of movement. And the reason is that your disc is a joint, okay? It's an actual joint that's moving every time you move your back. And so that's why pain from a herniated disc is so difficult to manage, because we're all on our feet every day moving around and you're using your spine. Shot. Let's go lateral. Is that uncomfortable for you at all? Okay. Shot. All right. Right there, is it? It's a little grainy. Shot. Yeah, I think that was the issue. Was we were just shot. We were too far south to get to this disc properly. So I'm glad we moved further north. Shot. But basically, the reason why it hurts with movement is that you have your disc is a joint, and that joint, every time you move your body, you're putting pressure on that damaged disc. That's painful, and that pressure on the disc pushes more of the jelly out. Shot. Where do you feel that? In your back? All right. Shot. AP. And when the jelly squeezes out from the center, the nucleus pulposus comes out into the tear, it creates more inflammation. That's it? All right, go back to a lateral. That looks good. So it's just like if you had a damaged knee joint that was inflamed and hurting you. Every time you start walking, putting weight and pressure on the knee, shot, it's gonna hurt, and then you got to rest it, right? Shot. Is that uncomfortable or is that okay? Where do you feel it? Shot. Mm-hmm. Where's that? Back? All right, well, we've got 2 out of the 3 bad discs tagged, for lack of a better word. And I'm going to see if I can get, we're probably going to have to make 2 little incisions, right? We talked about that possibility. Try to do it all through one, but I'm not going to be able to do all 3 through one. So we're going to have to make 2 incisions, which you really won't care much about, I don't think. They're tiny. Shot. Let's go down to the next level, down. And then let's get the end plates lined up. So to use X-ray in the operating room for navigation, you have to be able to line everything up properly. So we have a technician who runs the machine. That looks good. And she's doing a great job. Shot. Shot. It looks like we should be able to get this one with the same incision. Shot. Let's see where we are. We're right at the facet joint of 4-5. Let's go AP. So while we're doing the surgery, the staff that are working within 6 feet of this X-ray machine, that's perfect. Let's go back to a lateral. The staff that are working near this X-ray machine that we use, it's called a fluoroscope. We all have lead. We also put lead on the table to help protect the patient as much as possible. And again, you know, if you have a surgical procedure with fluoro as a patient, you want to try to minimize, you want your surgeon to minimize that X-ray exposure. Shot. And what I've done is I've looked at our X-ray exposure numbers over the years and noted that, shot, that we do have very low amount of exposure for our patients, so compared to other surgeons. And part of the reason is because we're very frugal with the use. Shot. Let me know if you have any discomfort. Shot. It's a little higher than I want it to be. Shot. Shot. Try to cone in because you're getting my hand. I don't know if you realize that. That's better. All right. I'm trying to work around the other needles we have here. Shot. Shot. It's a little higher than I want it to be. Shot. You feel it there in your back? Okay. Shot. Just can't get around that facet. Right there. Shot. Shot. That's better. Shot. Where do you feel it? Shot. In the back? But not down your leg. Shot. That's the most important thing, is not down the leg. Where do you feel that? Yeah, that's one of your bad discs. So I got good news. We're not going to have to keep you awake much longer. Let me know when it's comfortable. So at this point, we've got all 3 needles in to the disc, and the needles really are the way that I can access the annular tear that needs to be repaired with the laser. That's how I access it safely, because I use the needle to navigate around the nerves and the spinal cord and all that stuff and the bones, and basically to get right where the tear is, right where his painful tear is. And we're going to go in now endoscopically and repair those tears. Before we do that, we have one more step. Are you comfortable? Okay. So I was able to do all 3 with two incisions, okay? So you have 2 nice little scars you can show all your friends. And you can tell them that's where Dr. Duke got you. Are you comfortable? All right, how bad is that on a scale of 1 to 10? 10. Is that where you typically get your pain? That was your first disc. We just verified that it's indeed a cause of your pain. That's good news. That pain will be gone once we're done with your surgery, okay? I apologize. I wish there was an easier way to do it. Yeah, well, we're verifying that those discs are the cause of your pain. Same thing? How bad? Scale 1 to 10. 8. Really? All right, 9. Typical pain? Yeah. That was it was saying, so it was a 10? That was 4, 5? 4, 5? Yeah, L2-3, L45 so far, 10 out of 10. What we're doing, folks, is a discogram. It's called an evocative discogram. Evocative chromodiscogram, if you want to know the absolute real name. But try not to make it too complicated. How bad is that on a scale 1 to 10? Typical pain? All right. Well, all 3 of those discs on the MRI that I thought were causing your pain, based on where it's located on your body, they're all 3 were causing pain. Okay? We're going to fix them right now. And you're going to go to sleep, and when you wake up, that pain will be gone. All right. I need you to do me a favor. Count out loud from 1 to 100. Keep going. You're doing good. All right, so far what we've done is we've injected the blue dye, which I used to find the annular tear and the herniation. We've also tested those 3 discs to make sure that the surgery we're about to do is necessary for those 3 discs, which it is. And now we're putting our patient to sleep. So that way he's asleep for the more difficult and painful parts of the surgery. Keep going, you're doing good. I have my patients count out loud. That way I know when they're asleep because they stop counting when they're asleep, right? So when they stop counting, I know I can resume the surgery. That's a trick I learned from Dr. Albert Roten, one of my faculty who taught me at Shands Hospital Neurosurgery. Keep going. He used to do a procedure called a radiofrequency ablation of the Gasserian ganglion, which is the trigeminal nerve, to treat tic douloureux, which is trigeminal neuralgia, one of the most painful conditions in the body. And these patients would have pain shooting from their jawline down into their upper lip, or in their jaw, into their lower lip, or even on their forehead. Take a deep breath. Are you okay? Keep counting. Let me know when I can proceed. So Dr. Roten became world famous as a neurosurgeon for treating trigeminal neuralgia with radiofrequency ablation. Is he awake? Can I proceed or should I wait? All right, so we're gonna come down the guide wire. It looks like the first disc we're treating here with the guide wire is going to be the 3-4. And you can see the 3-4, it almost looks like a cotton ball with the dye in there, but it's not. You can actually see the dye is leaked out through a tear. And you can see a double density, which is actually because the vertebral body's rotated. You can actually see the disc herniation. It's like a fingernail clipping that the guide wire passes through in the back of the disc, actually in the foramen. So that is dye going around the herniation. And that's what we're going to be removing, is that with a laser, is the herniation and repairing the annular tear. Are we good? Shot? Okie dokie, artichoke. All right, so we're right up. I can feel the herniation. You can see it on the x-ray. The tip of the dilator is right there. And the safest way to get into the herniation is what I'm doing right now. Shot? And that is using a mallet. It looks barbaric, but it's not. It's actually much safer than me shoving this thing in, because if I shove it in, I could go too far. Shot. And I could go into the abdomen or pelvis and poke through the intestines, and that would be bad. So, the way we deliver energy, force, in a controlled fashion is in spine surgery is using a hammer. Orthopedic surgeons use all kinds of hardware as well, all kinds of instruments and hardware to bang things in and saw things and cut. Neurosurgeons are not so different. Spine surgeons are not so different. Anytime you're working with bones, how are we doing? Good? All right. Huh? All right, so I can proceed. I'm just talking to my anesthesiologist. Shot? Doing surgery is always a collaboration between the surgeon and the anesthesiologist. I need the anesthesiologist to manage the patient's vitals and keep their brain so they don't feel pain, or at least not consciously feel pain. All right, move the floor out, please. Okay, any questions from our audience?
None so far.
So for those of you wondering what we're doing here, we're repairing 3 herniated discs in the lower back of a patient who suffered with back pain, and we're going to basically cure his back pain. Can this be done anywhere else? No. Duke Spine Institute's the only place in the world that does this right now. We've been doing this for 16 years with the laser. Patients come from all over the world to have this surgery because they can't get it done in their countries where they live. All right, I'm looking for a mark on my tube. You see the whole surgery is going to be done through this little metal straw. Sean, you see the straw here?
Yes, we do.
All right. The outer diameter is basically 7 millimeters. That's why it's a 7 millimeter incision. The only other way to cure this man's back pain would be to do an open fusion surgery. Okay? And that would be, I'd have to cut him from here down to about here. So imagine that big giant cut. And then I have to peel all the muscles off the spine and retract them. There'd be a lot more blood loss. There'd be more muscle damage. And then I have to open the back of the spine, take the bones out, and then clean out the discs, the 3 discs that are painful, and then put new plastic spacers in there. And then put screws and rods in his spine. That's what I used to do before I learned this technique, before I developed this technique and learned this technique. So some of it's learned. I learned from my predecessors, and some of it's technique that I developed myself through modifications of techniques that I learned to make them better. And what we have now is the Duke laser disc repair. Okay, we're at L45, and right there, the blue stuff is the degenerated disc, the herniation. I'm going to try to pull out as much as I can, but as usual, using the pituitary rongeur doesn't work well. The laser is the most efficient, most effective tool you can use to do the surgery. And we're a little bit out of focus, so I want to try to focus this a little bit first. That's better. What we're looking at is the annular tear and the herniation. And I'm going to use the laser. Look how nicely the laser vaporizes. Now, I'm going to say something here. Most of the cases we do when I repair these tears and remove the herniation, the herniation is very collagenized. Collagenized means that it's scarred in from chronic inflammation. What we have here is some really not collagenized nuclear material. So it actually vaporizes quickly with the laser, and the laser makes quick work of it. It's kind of nice. So you can see how it shrivels up and breaks off with the laser energy very quickly. I don't have to deliver a lot of energy to the tissue to get it to vaporize.
We have another question.
So yeah, hold on a second. So more recent disc herniations that are newer are usually, they vaporize quicker. So I can't give you an exact date that this herniation would have happened, but when you're inside the disc like I am, you can actually get a pretty good idea of how old the herniation is. I can't tell you the day and hour, but I could tell you roughly how many months people have had it and whether or not it goes with their injury. Maybe if they had a car accident or a slip and fall injury or a work injury. I can usually date these herniations pretty well. Before I take the question, how is our first patient doing? They're probably ready to go home, as I would imagine. Can we check on them, please? Yeah. All right, so once again, the white is the annulus, the blue is the degenerated nucleus pulposus, for those of you who understand disc anatomy. The blue stuff is the jelly in the middle of the disc that's squeezed out through the tear. And it's not supposed to be there. It's not supposed to stain blue. The fact it stains blue means that it's degenerating. It's under the influence of inflammation over time. And the fact that, damn it. Let me see. The metal instrument is the pituitary rongeur. As a matter of fact, it's an endoscopic. Watch it, guys. Come on. Don't do Laurel and Hardy with me. Don't ask who's Laurel and who's Hardy. You guys don't know. All right, we'll take the question, Sean.
You may have just answered it a little bit, but we have a viewer wondering if you can explain what they're looking at. They're first-time viewers, so they're having trouble understanding what's on the screen.
All right. So the silver is the tube we're working in. Think of it as a straw. And you're looking out the end of the straw here, from inside the straw. And what you're seeing is you're looking inside the disc itself. And we're going to pull the straw back along the herniation. But what you're seeing is a tear, an annular tear. Okay, so the outer part of the disc tears and it lets the jelly from the center squeeze out. And it's the jelly from the center that squeezes out and comes in contact with the outer part of the annulus that causes pain. So we're inside the annular tear, we're cleaning it, debriding it. This is the first surgery in the world that has ever done an annular debridement. Nobody else has done it. I did it because I realized it was the annulus that was causing back pain and neck pain. Now, have people removed the annulus in the past? Yes, to do a fusion. But no one has ever just cleaned up the annular tear and debrided it. Debridement is a very specific surgical action. And basically you take an injured tissue, like a tendon, and you clean up and get rid of the areas of the tendon that are frayed, that have granulation tissue, that have scar tissue, so that the tendon can heal. And think of it as having a splinter in your finger. As long as the splinter's there, your skin won't heal, the inflammation won't go away. You just keep having redness, swelling, tenderness, and pain and warmth. And that's what this herniation right here, the blue stuff, is doing. As long as it's here, the disc will not heal, and you'll keep having back pain, inflammation, trying to heal it, but unsuccessfully healing it. And it can last for years, 10 years, 20 years, 30 years. So the blue right there is nucleus pulposus, which is the jelly inside the disc. Think of the disc like a jelly donut. You've got the jelly, and then you've got the donut part on the outside. The donut part on the outside is this white stuff, and there's a tear in it, and that tear happened from some traumatic injury this patient had. So who knows how he injured his disc? We don't know. Some people can never tell you how they injured their disc, but some people will tell you, I had perfectly normal life until I got into a car accident. Standby laser. And then once I got rear-ended or T-boned or whatever, I have back pain as a result and herniated disc. Well, that means the car accident caused the injury. Or if you're lifting heavy things like boxes or furniture and you feel a sudden pain in your back and then you have a herniated disc as a result. You've obviously torn the outer part of the disc, the annulus, and you've allowed the nucleus to come through and wedge itself in to the tear and set up inflammation. And that inflammation is what causes the pain in the back or neck. And that's what this surgery fixes. It gets rid of the inflammation by getting rid of the nuclear material that's stuck in the annular tear. So once again, the white is annulus fibrosus, the blue is the jelly in the middle, nucleus pulposus. And you're looking in through the tear. The blue thing is the laser. And if you look carefully, you see there's a little tip that's glass. It's clear. Laser energy in medicine is delivered from one place to another, roughly about 8 feet from the laser machine, which sits here in the operating room. It's huge. Come on. It's the size of a suitcase, a big suitcase. And it's a $125,000 suitcase. And what it does is it creates an energy beam that comes out a tiny little port that we plug this blue wire into, and it brings the laser energy from the machine into the patient's body where we want it. And the tip of this fiber is exactly where that laser energy is concentrated. And the blue sheath around it is just a protective plastic sheath. Okay? So that's what you're seeing. The round tube that's silver is the tubular retractor that we're doing the whole surgery in. The blue thing is the laser fiber. The blue stuff down there that's stained blue and it's fluffy is the herniated disc. And the white thing is the annulus fibrosis that we're debriding. Hope that helps. Nope, you have to take it off properly. There you go. No. You've got to hand me the fiber the right way, okay? You don't get to hand it to me the way you want to hand it to me. You have to hand it to me the right way. Hand me the piece that I need right there, okay? You got to pay attention. Come on over here. Let go of that. Help Cam out. You got to teach him. I need the laser fiber, guys. Cam, when you put your shoes on in the morning, you have a right and a left shoe, right?
Yes, sir.
Have you ever put your left shoe on your right foot?
Yes, sir.
You do that all the time?
No, sir.
Why not?
I would say it's habitual at this point.
Because you use information to guide what you do, right? You look at the shape of the shoe and you know which is right, which is left. You have to use information to guide how you hold this fiber. You can't just wind it around itself. You have to lay it in loops that are on top of each other so that when you hand it back to me, it doesn't kink around itself and wrap around itself and become a knot, okay?
Yes, sir.
There's a method to doing everything, and you've got to learn it. You got to pay attention to the details, just like you do when you put your shoes on, okay? I can't teach that to you. You have to observe, and you have to teach yourself. Fucking A. Luis, why is this falling off? Has to be on properly. Guys, don't create new challenges for me. I don't like new challenges during surgery, okay? All right, right here is the tear. You see the pink stuff? That's granulation tissue. This is dripping all over my fucking leg. And now my leg is like Antarctica, okay? So don't let that happen, guys.
Yes, sir.
Pay attention. Cam, you got to do your job so Luis can do his job.
Yes, sir.
And do it properly. All right. So right here, what I'm doing, I'm using the laser to clean up the annular tear, removing things that shouldn't be here, like scar tissue, granulation tissue, so that it can heal properly. Okay? This is what's happening. It's the water's coming down here, getting on there, and going down there. You have to create a space between the drape and the cables.
We have a question.
Sure.
Someone asked, why do some other laser spine institutes advertise endoscopic surgery but then still do fusions on
Too fast, too not loud enough. I couldn't hear the question. Why did some other laser spine institutes, and then I couldn't hear you?
you? So they're asking, why do some of the laser spine institutes advertise endoscopic surgery but then still do fusions?
why do some of the other laser or laser spine institutes advertise endoscopic surgery but still do fusions? That's a great question. There's probably more than one potential answer. So one reason is that the patient chooses not to have endoscopic spine surgery once they get there and they learn more about it. Okay? So the other reason could be that the surgeon sees the patient and feels that the endoscopic surgery is not the right choice. Hey, can you move that IV pole again? It's just blocking my view. Can we just check that every case to make sure it's not blocking my view of that screen, please?
Yes, sir.
So one reason is the patient gets to the institute and the patient changes their mind and doesn't want it. The other reason could be that the surgeon changes their mind based on the patient's anatomy or whatever the surgeon's using as their decision. Now, there's another reason which is more sinister but probably very applicable, and that is that the institute is using endoscopic laser surgery as a marketing gimmick to draw people in. It's the old bait and switch. Once people get there, then they switch to a fusion, okay? Fusions pay more money. If you're a surgery center or a hospital, you're going to get a lot more money doing a fusion. I get a lot less money doing laser surgery, but I do it because it's right for the patients. It's best for the patient. It's safer, it's more effective. The other reason is that those other institutes don't know how to do endoscopic surgery. They just bait people in, and then they tell them that, they can't have endoscopic surgery for whatever reason. They make stuff up. I know for a fact that there's a laser spine surgery of, and you fill in the last word, could be Orlando, Brevard, Tampa, and I know for a fact they don't know how to do endoscopic surgery, but they get people to come in and then they switch them. I've even heard from people that they switch them on in the pre-op area. They get them to come in for the surgery on the day of surgery, and then they change the plan. So I know that the people that run that business are unscrupulous. They're liars, they're deceitful, they're fraudsters. That's all I'll say. I won't tell you their names, but I know that because they used to work here, and we basically got rid of them because once we found out they were dishonest. I don't work with dishonest people. So we got rid of them. But they're still in the area and still advertising that they do laser surgery. And I've heard from people that went there on the day of their surgery that they tried changing them to a fusion. We don't do that to people, ever. You come to the office, we meet with you, we'll give you your options. If fusion's an option, we'll tell you it's an option. If laser's an option, we'll tell you it's an option. And then you decide, you go home and decide what you want to do. But when you show up for surgery at Duke Spine, we do the surgery we told you we're going to do. We don't do a bait and switch here, okay? Now, some people get upset because they find out their insurance doesn't cover as much of their surgery, but they don't find that out on the day of the surgery. They find that out in the office or after they've visited with us. Once we talk about their surgical plan, some insurances cover more than others. Others cover less. But that's not something that we can control. If you have bad insurance, you have bad insurance. That's not our fault. We didn't pick your insurance for you. You picked it. So the problem is insurance companies do the bait and switch all the time with people. They tell them they have great benefits. You have great insurance, really, really good. We cover everything you need. And then when they find out they don't cover certain things, you should get upset with your insurance company, not with us. So I don't know if I've answered your question. I've tried. But at Duke Spine Institute, you're never going to come here on your day of surgery and then be told you need a fusion instead. That doesn't happen. We don't do that. We plan every surgery in the office during the office visit while we have the patient, the MRI, the EMG, the x-rays. We know exactly what we're going to do on the day of surgery, and when people show up, they already know what surgery they're having, and we don't change it. We don't change it at all. Okay? So I can't speak to why other facilities change the plan. But I know some of the reasons because I talked to patients who have been there. And the reasons they tell me are they didn't think I was a good candidate for the laser endoscopic surgery, or I decided I didn't want to pay for it, or, you know, the more common thing is they bait and switched me. Bait and switch. The oldest trick in the book. Bait and switch, right? It's unfortunate, but there are people that do that. Now look here, this is very important. You see that red stuff, the pinkish stuff? That's where the pain comes from. We've been zapping it away, but that's the annular tear. That pink stuff is granulation tissue. And that granulation tissue has little nerve fibers in it that are super tender. And anytime you bend and twist and move, it sets them off and you get back pain, okay? This is what I discovered. You talk to other doctors about it, they will look at you funny because they have no clue about this. There's only a few people in the world that understand the pathophysiology of discogenic back pain or neck pain, and it is the granulation tissue within the annular tear. And this whole surgery I do is based on my knowledge of that, my discovery of that. And it, by the way, it's something that I did discover by treating patients for herniated discs. I found that we could cure not just their leg pain, but we could also cure their back pain. It was a bit shocking to me when it first happened, like the first 20 or 30 patients that we successfully cured their back pain and their neck pain by doing the discectomy. And then I realized it wasn't the discectomy that was curing their back and neck pain, it was the annular debridement, which is cleaning up the annular tear. And that's when we published it, 8 years ago. I figured it out before 8 years ago. I figured it out about 12, 13 years ago, but we didn't publish it for a lot of years. There was no reason to. I'm not in medicine to publish things. I'm in medicine to cure people's diseases and what hurts them, what affects them. So publishing things doesn't do that. Operating, seeing people in clinic does. Practicing medicine does. Okay, did I answer the question?
I believe so.
So we're just about done here, and we're almost done with the first disc. We already know, if you joined us late, we tested all 3 of his discs that were bad on the MRI, and all 3 of them are painful, okay? All of them are causing either a 10 out of 10 pain or 9 out of 10 back pain. And the way we know that is we did a discogram, an evocative discogram. A lot of people don't know what that test is. It's not a common test, but it's a way for the doctor to test the herniated disc before doing the actual surgery on it to make sure that it's the cause of the patient's pain. And at Duke Spine Institute, we're here to cure your pain. We're not here to treat discs. We're here to do what's necessary to fix pain. And sometimes it's doing this kind of surgery that's necessary, but I want to make sure, so that's why we do an evocative discogram at the beginning of every Duke laser disc repair. The discogram is part of the procedure. It's not extra. It's included in the cost of the procedure. Discograms themselves, I've seen facilities charge $100,000, $200,000 for. We include it in the surgery. And we probably charge somewhere around $5,000 for it, So we're not here to rip people off. We're here to get people better. And to do that, you have to be reasonable with what you charge. This surgery you're watching costs a fraction of what a fusion costs. Probably 25% of what a fusion would cost. So the laser surgery is cheaper, and the recovery is 1 hour, whereas a fusion is months, if not years. And the success of this surgery is 95% getting rid of pain, curing 95% of the preoperative pain. Okay, fusion, most fusion surgeries, they're lucky if you get 50%. So we have better curing of pain, laser off. We have a faster recovery, which is 1 hour versus 1 year. See if we can see the nerve. There's the nerve right there. See that? Pretty cool, huh? That's the dorsal root ganglion. That's the disc that we fixed. So, gonna suck all the water out, and we're done. Scope off. Yeah, please do. When I say we're done with one disc. We're not done with everything. So don't get excited. We're done. Take. So you're saying he's ready to go home? Does he want to go home now? If he wants to go home and he's stable and he's awake and alert, you can send him home. I don't need to see him before he goes home. So the first surgery we did, the patient's already ready to go home. The recovery from this surgery that you're watching is an hour. And this whole surgery, you can bring the floor in, I'm waiting for you. The whole surgery is done outpatient. We don't go to the hospital. You don't want to go to a hospital for spine surgery. Why? Hospitals have infections. That's where the bad bacteria live. They live in hospitals. Okay? And some people are going to take offense to what I say. Frankly, I don't give a damn. You can take a shot whenever you're ready. That's good. Yeah. I'm not here to make friends, folks. I'm here to provide you facts. Whether you believe me, you care about how I present it, I frankly don't give a damn. I'm too far along in my career to really care what you think. I'm here to teach you. If you want to learn, if you don't, fine. Stick your head up your ass. I'm not here to be your friend. I'm here to educate the public about spine care. So understand that. I'm not here to make friends with anybody. I'm here to teach people how to get out of pain. Whether you like it or not, you can turn off the channel and go watch something else. But I'm here to provide you facts. And I have no reason to provide you anything but what I truly believe are the facts. And if I don't think they're facts, I'll tell you I don't think they're facts. If I'm guessing, I'll tell you I'm guessing. All right? But we want to make this whole experience for people interactive, educational, and most importantly, truthful. Okay? That's the problem in the world today is, especially in medicine, you don't know what the truth is. Okay? For example, when you have cancer and you go to the cancer doctor and they want to give you chemotherapy, are they truthful about it? Some are, some aren't. A truthful doctor will tell you, this is chemotherapy. It probably only has a 5% chance of saving your life, and it's going to make you feel miserable with nausea, vomiting, and you're going to feel horrible. And it's only got a 5% chance of keeping you alive. That's facts, you know. Unfortunately, that's where we are with cancer treatment. The good news is now with curing back pain and neck pain, it's curable. And we cure it here at Duke Spine Institute. So that's a fact, all right? But you have to travel here to get the cure. We can't ship it to you. We can't mail it to you. Someday, there will be other centers doing the same surgery. Shot? As a matter of fact, I'm sure there will be very soon, because it works. And we have literally hundreds and hundreds of videos of patients who have had the surgery that I've been doing for 16 years now. And we've been videoing them for about 16 years. So if you go on the internet and you go to YouTube, you'll probably find videos of Duke Laser Disc Repair, Duke Spine Institute. We have about 1,000 of them that I've been putting out there for years to try to educate the public about how they can cure their back pain, okay? What we want everyone to know is that there is a cure.
We have another question.
Sure.
One of our viewers said, I saw your post on Facebook. How is your son's racing career going?
Oh, that's very sweet. Thank you. So someone saw a post on Facebook, how's your son's racing career going? As long as we don't have another spine-related question, I'll digress. Arias Dugmajan is my son, and he's doing really well in racing, as a matter of fact. You know, for those of you who don't know much about racing, usually professional race car drivers start with go-karts. And he started with go-karts too, just like everybody else. Shot? And he's still in the go-kart phase, and then you go from go-karts to cars. And we haven't made that jump yet, because to go to cars you need a lot of money, which I don't have. I'm not rich. I'm well off, but I'm not rich enough to throw my money into cars. So Cars are expensive. The level that he's going to race at, hopefully, is a Formula One level. We believe he's probably the best driver in America. He's ranked #1 right now in go-karts in the United States, Canada, and Mexico, basically North America, in the professional level and pro level. And he's driving better than he's ever driven. He's incredible. Very, very, very patient, smart, fast driver. So from a standpoint of his development as a driver, it couldn't be better. But as far as getting sponsorship to go into cars, we don't have it yet. And we're still waiting for his agent to get us that sponsorship. Hopefully she'll come through and do that. But, you know, if you've ever watched the movie Cars, with Lightning McQueen, which I watched 15 years ago when my kid was just 1 year old. He loved that movie, by the way. Yeah, that's the painful part. Sorry, buddy. But if you ever watch the movie Cars, the Lightning McQueen had an agent. He had an agent. You never saw the agent in the entire movie. And the reason is agents are they're off in their own world somewhere. And I thought it was pretty funny in the movie. You always hear the agent squawking on the voice box, but you never actually see the agent with Lightning McQueen, with the driver. And they're always, you know, telling you they're working on getting you sponsors and stuff, but you actually never see them. So that's kind of what it really is like. I thought it was a joke, but it's real. So anyway, I'm sure our agent's working hard, and hopefully soon he'll have the sponsorship he needs to go to Europe and race Formula 3, because there's really no other pathway to Formula 1 other than to go to Europe and race Formula 3. We have to go to Europe and race Formula 3. But that's $1 million a year to you have to pay to just rent the car and the team to race. So Arcos, we've really got to time better where we get the patient under better control at this point. It's great that he's snoring when I'm zapping the inside of the disc, but we really need them more comfortable now. We got to work on timing. Shot? So, long story short, go-karting career is fantastic. Car career is non-existent. We have to make the jump to cars at some point, but we need a sponsor to do that. He's a very sponsorable driver. He's very intelligent, very kind. He's always wearing his go-kart sponsor shirts and shorts, and he even made shoes because he is sponsored in go-karting by a team called Kart Sport North America, and they basically are the importers of an Italian chassis for go-karting. And for those of you who don't know, go-karting is not just like go to Andretti Park and go around at 35 miles an hour in a go-kart. These go-karts that he drives at the professional level do 90, 95 miles an hour, and suddenly they have to brake and turn and go in a chicane. It's exactly like a Formula One racetrack. You have straightaways, you have turns, and you have chicanes. And so his go-kart is manufactured in Italy by a company that has a distributor in the United States, and the United States distributor is his current sponsor. And so he's very loyal to his sponsor. He's always wearing their apparel and Duke Spine Institute apparel. But unfortunately, we don't have the funding right now to go to Europe and race cars. Now he will be going to Portugal in a couple of months, the beginning of November, for the World Championship in go-karting, where some of the best drivers in the world go to race against each other for the title of world champion. Arias has been the national champion in the United States. He's now really the champion of North America, but he has never won a world championship title. And so we're now into the next disc. This is the L45 disc. And I want you to look at it just for a moment. If you've watched a lot of these surgeries, Notice how the disc material is like in the flow of the water. We have the same water flow in every case, but notice how it just kind of wiggles and moves. Like it moves freer, right? That means it's less scarred together. When you see it all clumped together, stuck together, that's more scarred. Now look at the pink stuff. You see the pink color right there? That's granulation tissue from chronic inflammation. So this is a painful disc. We know that because we tested it. And now we're going to zap away all this grunge in here and let this disc heal properly. And when it heals, as a matter of fact, right after the surgery, there will be no pain. But we want it to heal without pain. That's the goal here. That's what this surgery does. It cleans up the herniated disc so that it can heal without pain. So I gave you a little synopsis on Arias, where he's at. We're just kind of waiting for his motorsports agent to get him a sponsor so that he can start racing cars, and then he can show the world what he's really capable of doing. Arias has raced a couple of times in cars. He raced something called the Radical prototype in Miami, and he had no practice. He literally blew the practice. We missed the practices. There were 2 of them, and he went straight to the race. He even missed qualifying, and it's his first time ever in that car. Never even driven this car before, a Radical before. He'd never driven a car that wasn't open wheel. He'd only driven a Formula 4 car, and he got in that Radical car, and he finished the race in second after starting last, dead last. The kid has an incredible ability to control cars and get the most out of them. It's pretty impressive. He's a very aggressive driver, but also very patient. So hopefully we're going to have more videos of his driving online soon, so you can actually watch some of his driving. In Europe, the Europeans video the races really nicely. You have high definition color videos of the go-kart races. In the United States, we don't have those systems available. I mean, they're available, but nobody spent the money to do it. And we really need it because it's fun to go back and watch go-kart races. The Europeans usually have thousands and thousands of views. So I don't know why we don't do that more in the United States. You can sell sponsorship spots on the videos. So it's unfortunate because now it's hard to post videos of the drive. You can either do GoPro or you can do a camera from a fixed point. But in Europe, they actually have multiple fixed point cameras, high definition. So you get like 8 different perspectives of the track. And you can really watch the race unfold properly with commentators. We don't have that in the United States. So we're a little behind in Europe in terms of broadcasting go-kart racing. But I think that's going to change hopefully soon. And in the next year or 2, we'll have better systems available. I know Xander is trying to do that with e-karting news. I think it would be great for them to broadcast that race. The races, the big ones. All right, any more questions about the surgery?
We do have one viewer who has a question about their own back pain.
Okay, about low back pain?
Yes, her question says, my MRI results are back. I have 3 herniated discs in my lower back. I have pain in my buttocks and legs. I've had several medial branch blocks and put on different pain meds, but the doctor wants to give me another block even though my pain is not improved. Do you think I should do another block?
Great question. So one of our viewers says, look, I've got 3 herniated discs in my back. I've had the blocks done before. They don't seem to work. Should I have another block done? The answer is really no. I wouldn't. You might think that pain blocks are totally harmless, but I've seen people get infections from them. I've seen people get hematomas or blood clots around their nerves from them and need emergency surgery. Obviously, the medicine injected also is a steroid, so it's going to give you, a steroid effect on your whole body where your blood pressure goes up, your sugars get out of control. You can experience, basically, they call it steroid psychosis, but there's anything from bad dreams to agitation to real psychotic behavior where you're having hallucinations and delusions. So those shots aren't just totally benign. And if you hadn't had them already, I would say yes. But the fact you've had them and they didn't work, they aren't going to work. So my advice is get your disc herniations fixed. And the surgery you're watching right now is the perfect surgery for that. The alternative would be to do a fusion, to clean out those discs and do a fusion of those bones, which is really, really overkill. But this surgery is perfect for herniated discs that are painful. And the patient you're watching, got to watch that on my face. Can't let it hit my face, okay? You got to get your hand up here. Are you understanding me, Cam? The surgery you're watching right now is like literally perfect for a 3 herniated discs. The incision is 7 millimeters. This patient will be fully recovered in an hour after the surgery, and they're going to go home basically an hour after surgery. You can't do that with a fusion. With fusion, you're going to be in pain from the surgery itself, a new pain you've never had before. It's going to hurt like hell, and you're going to be on powerful narcotic painkillers for months and months, okay? Just recovering from the surgery, from the incision and the muscles being moved over. So this patient and all the Duke laser disc repair patients, they don't take narcotic painkillers. We give them an anti-inflammatory and a muscle relaxer. And most patients that have the Duke laser disc repair, they take it for 1 day and they're done. And then they may take Tylenol for a day or two. Basically, the incision is so small it doesn't hurt, okay? So in my advice, have this laser disc repair done to fix your herniated discs. Don't waste your time with more injections. Don't waste don't take the risk that you don't need to be taking for more injections. Get the disc herniations fixed. Now, if you choose to get another block, I don't think it's horrible. I mean, there is some risk associated with the block, but pretty, safe as long as the doctor knows what they're doing and they use good medicine. Your risk is very low, but it's not zero. So the blue fiber is the laser. You can see it blasting away at this white material and blue material. And this is really the herniation. A herniation is really the jelly from the center of the disc squeezing out through a tear in the capsule around the jelly. So there's 2 parts to every disc. There's the annulus fibrosus on the outside, and then there's the jelly in the middle called the nucleus pulposus. 80% of your disc is jelly, nucleus pulposus. 20% of it, the outer 20% is the capsule. It's a really dense capsule around the jelly, holding the jelly in place. Now everybody thinks the discs are painless. They don't cause pain. That's because everyone oversimplifies things. And they think that, discs don't have nerves and they don't have blood supply. But actually they do have nerves and they do have blood supply. But the blood supply and the nerves are on the outer half of the annulus fibrosus. Well, when you get a tear in your annulus fibrosus that travels from the inside of the annulus to the outside, we call that a grade 3 tear. And that tear will allow the jelly inside the annulus, the jelly in the middle of the disc, that 80% jelly, the nucleus pulposus, that tear allows the nucleus pulposus material to squeeze out into the tear, out and then outside the disc where the nerves are. So that's what we're repairing with the surgery, is that tear. And at the same time, I'm zapping away the jelly, the nucleus that's stuck in the tear, that's been causing all the inflammation and pain. So it's really an amazingly simple procedure that nobody really knows how to do because we discovered it here at Duke Spine. I didn't discover endoscopic spine surgery. Don't get me wrong. I'm not the first person to do that. Dr. Parvis Camben is in Pittsburgh, but that was back in the 70s. It just never caught on. I'm not the first person to do transforaminal surgery, going through the foramen. There are others before me that did. I'm not the first person to use a laser to zap away disc material. Other people did well before me. But I am the first person in the world to debride the annular tear, which is the cause of back pain. Of course, I discovered that in the process of doing debridements. as part of treating patients with herniated discs. And I published that information back in 2012, and you can find it in PubMed, Duke laser disc repair, just look it up. We are almost done. What you're seeing at 12 o'clock right there is fat and a little bit of connective tissue. This is the back of the disc where I'm at. You see the blue right there? That's nucleus pulposus in the back of the disc. Luis, how are our scopes?
Good. They're good.
Being maintained good?
Oh, yes, sir.
Yeah.
We have another question.
Luis is in charge of our sterile processing department. He's done a wonderful job, and he's training Cam right now. Yes. I'll take the question.
One of our viewers is wondering, how long after the surgery will this patient's life be able to return to normal?
Okay. So Sean, either I'm losing my hearing or your voice is trailing off. I apologize, Sean. I don't mean that in a bad way, but I heard how long after the surgery and then blah, 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 blah.
Will this patient's life return to normal?
How long after surgery till this patient's life returns to normal?
Yes.
Great question. So this patient's back pain that they've had for several years now, that they haven't been able to get rid of, will be gone when he wakes up. I mean, it's gone as soon as I'm done with the last disc. It'll be gone. And the patient will be fully recovered in 1 hour. So their pain will be gone. They'll be fully recovered in 1 hour. But they will have restrictions. And those restrictions are bending and lifting. He cannot bend at his waist for 6 weeks. That means bending over to pick things up from the ground. You understand? Oh, I want to pick my sock up off the ground. No. I want to bend over and grab my shoe. No. I want to pick my little Cairn Terrier up and hold it from the ground. No. You cannot bend over and pick things up, period. And that's 6 weeks. So when can the patient go back to work? Tomorrow. Tomorrow. These patients can go back to work the next day. Okay? Does that mean he wants to go back to work the next day? Not necessarily. And if his job requires him to lift heavy items, he can go back to work at light duty, but he cannot go back to work lifting heavy items, okay? That's not acceptable. So we get a lot of people who go back to work light duty the next day. But you can drive the next day. You can go shopping the next day. I mean, there's really not much you can't do. You can't go on a roller coaster the next day. You can't, lift heavy things the next day. But you can start walking down the street, getting exercise. You can lift very light weights the next day if you want to. Laser. So really the only restrictions are bending and lifting. Otherwise the patient will look absolutely normal. If you see this patient tonight, you'll never know they had surgery. You'll never know it. They'll be normal. They'll be eating normal, drinking normal, normal talking, normal thinking. It's incredible. Now if you had a fusion instead, he'd be doped up in the hospital. If I didn't do it, if somebody else did his fusion, like any other spine surgeon, he'd be in the hospital doped up on something called a morphine PCA, which is like a machine that pumps narcotics into your body constantly, and then you can hit the button and give yourself a boost. And when I did my training at Chan's, the best spine surgeons in the world, they would use those PCAs after surgeries on people's backs, and the patients would be there for a whole week in the hospital, just doped up. And I thought, my God, there's got to be a better way to do this. That's why we came up with this technique. So the recovery is dramatically different, okay? And the people that have open back surgeries need a lot more painkillers and much longer time to recover. Just letting you know that. All right, just about done with this disc. And then we're going to have one more to go. Okay? And the white stuff there at 12 o'clock, that's the posterior ligament. Okay, posterior longitudinal ligament. And it's really nothing important other than just to know it's there. Normally the posterior longitudinal ligament sits behind the disc, okay? So you're going to have the disc, the annulus, and then behind the annulus is the posterior ligament. All right, stand by. Let's see if I can get any more of that with the grabber. Really not much else to grab. That's about as much as I can do. Let me use the laser one more time. Any more questions, Sean?
We do have one. One of our viewers is wondering, going forward after DLDR, what can be done by the patient, such as diet, supplements, or exercises to help renew the disc?
What can be done by the patient, such as diet, supplement, and exercises to help the disc heal?
Yes.
Yeah, good question. We get a lot of that. Question. It's a good question. It's a fair question. Really, if you think about the disc, it's at a disadvantage to other tissues in your body in that there's not a really good blood supply, which is why it takes a full year to heal, okay? Whereas like your skin will be totally healed within 2 weeks because your skin gets lots of blood supply. Your muscles healed in 2 weeks, but your disc is going to take longer to heal, okay? That's good. We're done. Laser off. Now, what could you do? You could do, some vitamins, regular multivitamin. You can do good nutrition, like a well-balanced diet, protein, carbs, a little bit of fats, leafy greens, vegetables, salads. Just fortunately, as human beings, we've been well adapted to do well nutritionally in our environment using what I believe is what I call an omnivorous diet. An omnivorous diet means you eat vegetables, you eat meat, you eat fruits, a little carbs. So basically just having a regular omnivorous diet. But if you don't do the omnivorous diet thing, then just vitamins, whatever your normal diet is. Probably the most important thing to help your disc heal properly, put pressure, is the activity restrictions. Because if you bend over and pick something up or you carry something too heavy, you're going to load that disc that I just fixed with weight. And as you load it, the bones will literally crush down on each other and it'll push out another piece of disc material. So once you get a second herniation, it's not going to heal itself. It's going to need another surgery. So the most important thing you can do is activity restrictions. Limit your bending and lifting. Second is nutrition, just regular diet, whatever you normally eat with a vitamin if you want. The third thing is avoid tobacco use. That's smoking cigarettes, nicotine with chewing tobacco. And the reason is that the nicotine in tobacco, the nicotine which is in all tobacco, and that's the addicting component, that's the chemical that you become addicted to with tobacco use is nicotine. That nicotine is something called a vasoconstrictor, meaning it narrows your blood vessels. It causes your smooth muscle cells around your arterioles to constrict, and basically it shunts blood flow away from areas that need blood flow. So you want to avoid tobacco and nicotine products. Okay? That's it. There's really nothing else that makes the disc heal faster. Now, will that change over time, over the next 10 years, 20 years? Probably. We'll probably find things that can make the disc heal faster. But today there's really nothing else. So I don't, I could certainly take advantage of that and sell you a Duke Spine supplement, but the truth is that I don't ever feel good about trying to give somebody something they don't need that I don't believe in the benefit of. So we don't do that because there is no supplement, okay? And I don't make stuff up like other doctors do. Take. All right, we're doing our last one. Thank you for doing that. We're going in. This is going to be the 2-3 disc, the L2-3 disc. So just take a look at what we got so far. You can see the first incision. We did 2 disc repairs through that little 7 millimeter, and now we got to do another incision. So I use an 11 blade, okay, an 11 blade to make my incisions. And a little secret I haven't really talked much about. The further up the spine you go, the more medial you need to go. The more closer to the midline. Okay? So if you notice, I moved a little bit more medial to do the next incision. Shot. We're going to get this needle out, keep the guide wire. Look how I hold it. I don't let it move. Got rid of this spinal needle. And then over the guide wire comes the dilator. Here's what the dilator looks like, just in case you wonder. It's just like a long, skinny pencil. A very expensive pencil. And then look at the tip right there. You see that? That's where the guide wire goes in. And the tip of it is tapered. It's called tapered. Basically, it goes from skinny to bigger. And the big side here is what we slide the tubular dilator down, or tubular retractor down. But this spreads the muscle, this little tip of it. It literally spreads the muscle open, and when we take it out, the muscle closes. So you don't actually cut the muscle, okay? And just under the skin is the muscle and fascia. So we're actually, I need the skin knife again. Skin knife, yeah, the 11 blade. The 11 blade. So there we go. There's a little piece of skin holding that there. All right, now we're going to advance this down shot. Want to make sure the guide wire is not moving. We're going to come down. I like to twist it and a little bit of pressure as I'm going in. Keep my eye on the dilator. The guide wire. I don't want the guide wire or dilator to go somewhere it's not supposed to go. All right. Shot. And just for the record, there's no way I could have gotten this next disc through that incision. The angle was too steep up. I tried, but I couldn't get it. So I had to bite the bullet and make a second incision. So we're going to do 3 discs through 2 incisions today. Normally we can do all 3 discs through 1 incision. But it all depends on the angulation of the spine. Shot? Okay. I don't want to pinch the guide wire. I want to make sure I'm following the guide wire properly. Otherwise, if you pinch it, you won't be able to get it out, and it can actually break inside the patient. Shot? And that would be bad. Yeah, you don't want to break a guide wire in a patient. Oh, that's bad. Really bad. Really bad. Never done it. Not going to. Shot. I think that looks good. We're going to go a little bit further. Y'all see that? Ooh. My left hand is not as coordinated as my right hand, but it's not bad. It's not bad. My advice to you, become ambidextrous. I'm serious. If you want to be a good surgeon, you have to use both hands. All right, that's exactly how I started. I started becoming ambidextrous when I knew I wanted to be a surgeon. I started brushing my teeth with my left hand. And then whenever I went to Chinese food, I would use my chopsticks. I teach myself to use chopsticks with my left hand. And then I started writing with my left hand. So it's a process, but you can train your brain to use your non-dominant hand and develop coordination and skills. Sean? So it's pretty funny though, if you watch me operate, many of you have watched me operate a lot, you notice that I'm comfortable using either hand when I operate. But you'd be surprised, many of my co-surgeons that I trained with, they can't use their left hand, or their, opposite of what they normally is a dominant hand. And they struggle, and you have to see, you'll see them, they'll literally turn their bodies, and they'll literally drop one instrument, pick up the other with their right hand. And it creates, I think, a safety risk for the patient if you're not able to use both hands, but it also affects your efficiency of your surgery. So all the aspiring surgeons out there, become ambidextrous.
Stop on, please. Lights off, please.
I first became ambipedous. Is that correct? Ambipedulous? Everyone's staring with like blank look on their face. What I'm trying to say is I learned, my feet. Okay, so most of you don't know this, but I was a semi-professional soccer player, and I played on the United States national soccer team back in the 80s. And we traveled to Europe and played against the Germans and Austrians and European teams representing the United States. I was one of the best soccer players in the country, for sure. So why didn't I go into pro soccer? Because there was no pro soccer in the United States back in the early 80s, okay? And if I did, I would have had to have gone to Europe and played in Europe. And I didn't want to leave America and go to Europe. It's that simple. I was already doing that, but I didn't want to live in Europe, okay? I was perfectly happy going for a few months playing soccer, but I didn't want to go there permanently at the time. So I was a striker in soccer. And when I was really young, learning soccer, I was right-footed, and I could only kick the ball with my right foot. And my dad told me, if you want to be the best striker, you have to be able to kick the ball with both feet. So he put me in front of the garage with a soccer ball, and he told me, kick the ball against the garage 100 times with your right foot and 100 times with your left foot. And of course, the first time I did it was horrible. I couldn't even kick the ball with my left foot. But after practicing almost every day, I'm not going to lie to you and tell you I practiced every day, because I didn't, but almost every day, I became really good with my left foot. And then it was just a matter of forcing myself to shoot with my left foot during practice and then the game. And I still remember the first goal I scored with my left foot. I was about 11 years old at the time. And of course, by the time I was 12, I was basically a superstar in soccer. And scoring goals every game, mostly with my right foot. But the nice thing about being left-footed was that I was a threat to the defense from anywhere I was. So the same thing with surgery. If you want to be a really good surgeon, you need to learn how to use both hands. Because in surgery, you don't use just one instrument at a time. Surgeons need to use 2, sometimes 3 instruments at the same time. And you want to be able to control the instruments with both of your hands. It makes for a much better operative experience. So Cam, I'm glad to hear that you're already training yourself to use your left hand. Sean, we have any more questions from our audience?
We do not.
All right, so it is September 10, 2020. We are in the process of repairing the 3rd herniated disc, 3 in a row here in this patient's back, the L2-3, L34, L45. And this patient really has 90% back pain. The back pain we determined is coming from the herniated discs that were found on the MRI. I expect 95% or more of his back pain to be gone after the surgery. And I expect it to stay that way. As long as he follows our restrictions of no bending at the waist for 6 weeks and no lifting more than 25 pounds for 6 weeks. After 6 weeks, we bump our patients up to 40-pound lifting restriction. Now, of course, everybody wants to know, when can I go back to golf? When can I go back to biking? When can I go back to running? You know, everyone wants to be active, and they should be. That's why we do these surgeries, to keep people active. Happily active without pain. So every activity that people want to know about, we consider them individually on a case-by-case basis. It depends on how many disc herniations you had, where those herniations were. Are they cervical? Are they lumbar? Are they thoracic? How bad was the herniation? Was it a huge blowout? Was it a tiny one? And then during the surgery, I look at these discs and these annular tears, and is it a big annular tear or a little annular tear? Most of the annular tears we're operating on are big. And I told you a grade 3 tear is a through and through tear. But there's also grade 4 and grade 5. And we haven't talked about what a grade 4 or grade 5 tear is. A grade 4 tear has a herniated disc passing through it. Okay? And it's through the tear and all the way through around to the foramen. And it's kind of sticking its little head out. A grade 5 tear is a huge disc extrusion. So it's a herniation, but it's just a big one that comes all the way out. So both annular tear grade 3, grade 4, and grade 5, so all three actually, not both, but all three, can have nucleus pulposus wedged into the annular tear. And it's that nuclear material wedged in the annular tear that's the cause of the back pain or neck pain or thoracic pain. There's three places you have discs, spinal discs. You have cervical, which is the neck, thoracic, which is the mid-back, and then lumbar, which is the lower back. By far, the lumbar or lower back is the most common place to have herniated discs, and it's by far the most common place to have painful herniated discs or symptomatic herniated discs. Okay? So the vast majority of spine surgery for disc injuries is done on the lower back. And, you know, that's true even in our practice, my practice at Duke Spine. Most of my patients have back pain. So about 1/5, 1 out of 5, or 20% have neck pain. And they come here for a neck problem. Now, is that because that symptomatic cervical disc herniations represent 1/5 of the herniated discs in the world that are symptomatic? Or is it because most people with neck pain don't think it can be treated, so they don't bother coming to see a neurosurgeon? I don't know the answer. All I know is of the people that come here to Duke Spine, 1/5 of them have back pain. One-fifth of them have neck pain and neck issues. 4/5 or 80% have back pain. Okay? So we treat both. We even treat thoracic pain, even though it's rare. We treat it all. And we treat it very well. Stand by. Look at that herniation right there. I'm going to try to grab it. See if I can get it out with the grabber. If you can grab out a chunk, it's always better than lasering it out, because the laser takes a lot longer. And if it's a piece that's just sitting there ready to come out because you've released it with a laser, then it's a lot more efficient, safer, just to grab it out. What we're dealing with, why are you seeing all these little things floating around? These are all pieces of disc herniation. When people get a disc herniation, it's never just one big piece. I mean, we'd love it to be, because then it's easy to fix, right? You grab it, pull it, and you're done. You're done in 5 minutes. Unfortunately, all these herniations are in pieces. Okay? Good. That's good. See how you did that, Cam? Smarter. See, if it was one big piece, it'd make my job easier. You see the tear right there at 12 o'clock? So we always talk about an annular tear. That right there is 1/2 of the tear, and over there is the other half. And you see the pink material? That's the inflammation in the tear. That's what we have to zap away. If we clean this up with the laser, it'll heal properly and there will be no back pain. That's, again, what the Duke Spine Institute is the first in the world to describe it and to do it. And unfortunately, right now we're the only people in the world that do this. Now see this stuff right here? It's kind of golden color. That's calcified tissue. So when your body gets an injury to its tissues, it calcifies those tissues over time. It doesn't happen overnight. It literally takes months for that to happen, if not years. So that golden color is the calcium. That's the laser energy reacting with the calcium, oxidizing it. Oh, look at that little herniation right there. See it wiggling out? Like a tongue coming out of the mouth. Pretty cool. So we've had some pretty good questions from the audience today. We always enjoy questions here during these live stream surgeries. And that's why we broadcast. We want to educate the public about what we're doing, why we're doing it, the results of what we do, how it helps people. I tell you, I was having a conversation with Sean earlier. You go on Facebook these days or any social media outlet and you could go into a group and you know, I go into some of these back pain groups or neck pain groups as Dr. Duke Majan, and I'll go in there and I'll say, you know, somebody's in there posting saying, I'm in so much pain, my back's killing me, my neck's killing me, I can't live with this, I've tried medicine and shots, it's not working, what should I do? And I'll go in there and I'll say, look, check out the Duke laser disc repair. We can cure back and neck pain now. And right after I post that, within 5 minutes, I'm going to have like 3 more posts against me saying, don't lie to everyone, you're crazy. How could you say you can cure back pain and neck pain? Nobody can cure back and neck pain. I'm like, no, really, we do it all the time. And they think I'm the Antichrist. And they boot me out of the group. I mean, you wouldn't believe the amount of disrespect I get. I'm just trying to help these people because what's the message going on in these Facebook groups, all right, is to somebody who comes in and says, I'm suffering, I'm in so much pain, my life's miserable, the people that are there just say, well, why don't you try eating some broccoli or blend up some mud with earthworms and rub it on your back. Try that. And it's like, are you freaking kidding me? That's not going to work. I mean, it's weird. But these people, it's like they want to continue to be in pain or they want to keep people in pain. It's the strangest thing I've ever seen. And then when I come in and I post a video of a patient whose back pain we've cured, they like try to boot me. They'll contact the administrator, get rid of this Duke Majan guy. He's just trying to sell surgery. No, I'm not. I'm trying to spread the word that you don't have to be in pain anymore and you can get cured. And you think that the people in these groups and Facebook groups would be supportive of a cure. I mean, fine, you don't believe me? Do your research. Go watch all the hundreds and hundreds of videos of people we've cured. You know, convince yourself. But don't diss the truth just because you're not the one to bring it to the group. Don't be a hater like that and make people that are in the group that are looking for solutions, legitimate people looking for solutions, don't condemn them to a life of pain and suffering just because you've got an ego. So, yeah, I'm not happy about, you know, some of these groups, some of these really big spine and pain groups on Facebook because it seems like they want to keep people in pain. Or they're peddling something to sell that doesn't work. Usually there's nothing that people are peddling. They just don't want people to be cured. It's the strangest thing I've ever seen. Totally unexpected. So if you're watching this broadcast and you're in one of those groups, spread the word. Let people know at least to come and find out the truth. Don't live in a quagmire of lies and misinformation and untruth. By the way, speaking of Facebook, Duke Spine Institute, we do have a Facebook group. It's called the Spine Surgery Support Group. It's open to the public. It's not an open group because we have to be able to kick the crazy people out that try to come in and sell things. I have people that want to come in and make a post about selling surgical instruments. It's like, why would the people in the spine surgery support group want to buy surgical instruments? They don't. You know, they're here to talk about back pain, neck pain. They don't want to buy screws and rods. So anyway, it's a group that we accept everybody, and really what the purpose is to share the truth about back and neck pain or spine problems. And people are allowed to post and also get their questions answered. We encourage it. So check out the Spine Surgery Support Group on Facebook, and you're welcome to join. There's no cost, and you can learn a lot there. The other thing you may want to consider is downloading the Duke Spine Institute app. We have a free app for Duke Spine Institute. You can download it to your iPhone. You can download it to your Android or your Apple computer, whatever it is. But it's a free app we created. We put a lot of work and effort into it. It's got great information. There's no advertising on it. We're not trying to sell anything. It's mostly a resource for information you can download and have available. What we've started doing, which is really good in our clinic, is patients who come to the Duke Spine Institute, we get the app downloaded on their phone, and we examine the patient, figure out what's wrong. And if, for example, if they have a herniated disc, we have a section on the app where we can click on herniated disc. And then they can leave the facility with all the diagnoses that they have as the cause of their back pain or neck pain. And of course, we have another section in there on treatment. So, you know, sometimes you go to the doctor's office and you're like, I forgot what the doctor said I have. Well, now you don't forget. Now we have it on your phone that you can reference it anytime you want, and it's in the Duke Spine Institute app. You just pull it up, and your diagnoses are going to be clicked for you. So they're unique to you. All right, this is a really scarred up area right here that I'm dealing with. Really scarred up area. Okay? And what we're looking at is we're looking at the inside of the herniation with the tear and the herniated fragments of the disc. And a lot of times these herniated fragments get scarred down to the annular tear. And that's what I'm debriding, is that scarred in fragments of disc herniation. What is our last surgery today? What do we have, another laser?
We have
A bilateral? They're really working me today. You guys know I'm getting to be an old man, right? They're laughing at me. They think I'm funny. And you should laugh at me. With comments like that, you're entitled to do that. All right, we have one more surgery today. It will be a bilateral Duke laser disc repair, apparently. A patient with bilateral leg symptoms, both sides. Bilateral means both sides. So we're going to be doing it on both sides. All right, just about done here. Doc, I think we need about 5 minutes and we'll be done. Just planning your anesthesia. Just about finished. Remember, you're looking down basically a 6 millimeter tube on the inside. The outside 7 millimeters. But the inside of this tube is about 5.5, 6 millimeters. And what you're seeing is that tear right there. Right in the middle is the annular tear. That's what I'm zapping away with the laser. Oh, and if you wonder, is that laser powerful? Just take a look right there at the end of the metal. See that stuff right there? That's melted steel. Guess what melted that? The laser. The laser. The laser can go through steel, no problem. Most people know by now that lasers are capable of cutting steel, that they're capable of cutting diamonds. So, when people say to me, can you use the laser to get rid of bone spurs? What do you think? Bone spurs are definitely not stronger than steel. And this laser melts steel like it's nobody's business. So it's another reason why you got to be careful with the laser. You want to go to a doctor or a surgeon who knows what they're doing with the laser. Otherwise you can get hurt pretty bad. Trust me, there's a lot of stupid surgeons out there. I've seen them. I've talked to them. I've worked with them. I've trained with them. Okay, there aren't a lot of stupid neurosurgeons, but there's a lot that don't have common sense. And you need somebody with common sense in the operating room. Sorry, but you do. You need someone who can think outside the box, make the right decisions on the go, so that you, the patient, doesn't suffer with bad decisions. Okay? We're not selling cars here. This is not a Toyota Camry, black exterior, matted finish, bucket seats, leather interior, camel colored, with the diamond patch, diamond stitching, whatever it's called. This is a very sophisticated surgery that can be done many ways wrong. If you buy a Toyota Camry, whether you buy it in Texas or you buy it in California or you buy it in Florida, it's the same damn car. Okay, because it's all manufactured in a facility that they have the same exact blueprints, the same materials, the same process, okay? But surgery of the spine is different. And even if you have a fusion here versus California versus Florida, New York, wherever, you pick the location. If you choose 10 different locations, the surgery will be done 10 different ways unless you move the surgeon. Even if you move the surgeon to 10 different hospitals, you're going to have 10 different surgeries because each hospital has different equipment, different staff, different drugs, different things to use. You understand? So even if you were to try to keep the surgeon the same, which is impossible, you can't have the same procedure done because every hospital has different equipment. Okay? So what I'm getting at, folks, is that a endoscopic surgery done at Duke Spine is definitely not the same as endoscopic surgery done anywhere else. What makes ours better is pure and simple one thing. Y'all know what that is? Who knows what makes our endoscopic surgery better? Cam? No, not me. That's cute though. Kind of feeling warm and fuzzy inside. But no, it's not me. What makes ours better? No, not going home afterwards. That's part of it. That's part of what? Luis? Luis is just laughing at me again. Who knows the answer? Recovery time. Close, but no cigar. That's part of it. Come on, audience. Someone give us the answer. I know Arcos knows it. He's just being coy. What is it, Arcos? Huh? Experience. No. The answer is results, folks. Results. What matters is the result. In the end, what matters is the result. The result means how much pain do we get rid of? The result means how many complications, or do we have a complication? What was it? How bad was it? The result means when did the patient go home? How fast was the recovery? All those variables that happen at the end of spine surgery, whether there's complications, whether there's pain relief, whether there's a long recovery, whether there's a short recovery, how big the incision is, all those things are categorized as results. So what makes Duke Spine surgery the best is our results. It's not me, it's not this laser fiber, it's not even this tube. It's the results that we get. And all these things are important for the results. All right, just about done. There's the end of the disc right there. There's the epidural space. You can see the end plate off to the right at 3 o'clock. This is the last part of the herniation. You can see fibers from the posterior ligament at 12 o'clock. So you know you're getting close. You got some fat there at 12 o'clock. See that? That's the epidural vein that's bleeding. And by the way, it's another thing about the technique that I do, the inside-out technique we were talking about earlier, is that it allows the bleeding to not come into the surgical field. So you have to be careful with that, because if you can't see the bleeding because it's outside the tube and it's being trapped outside the tube, you could be having a lot of bleeding and you don't know it, right? And you want to know it. As a surgeon, you want to know all the bleeding going on in the patient at the time you're doing surgery and after surgery. So you don't want to ignore it and hide from it. But the fact of the matter is there is no bleeding going on except for right there. And maybe a little bit in the muscle when I take the tube out, but we're going to apply pressure to stop it. So that bleeding right there, the epidural bleeding, is only happening now because I moved the tube back. So it's no longer compressing that vein. The tube itself is no longer putting pressure on the vein. Does that make sense? And that bleeding is minimal. There's like nothing there. Okay? Nothing. It's a wisp. If you do a diabetic stick on your finger, there's a lot more blood in a diabetic finger stick than we get during this whole surgery, basically. Okie dokie. It's 12:30. Not bad. My stomach is telling me it's lunchtime. Okay, just 30 more seconds and we're done. Arcos, are we ready? This is part of the herniation, by the way, laterally. You ready to wake him up? Okay. That's the end plate right there, that pinkish thing. And we're going to take a look at the nerve root again, just so we can see it, okay? I'm going to crank down a little bit so I can get a little more medial. I know it's a little hard to see because you have a little bit of blood in the water right now. If there were sharks in this operating room, we'd have a problem. Oh, I got Luis to laugh. All right. Okay. We're done. Look how nicely the laser kind of stopped that.
Lights on, please.
Oh, where's the nerve? The nerve is up here. Hold on.
1 second.
Hold on.
Off the
Let's see that laser. Sometimes I get up here and I get a little surprised. That's just fat and connective tissue. That there is a little bit of herniation, so I want to make sure I take care of it. By the way, we give all of our patients a copy of their surgery video so they can go home and watch it with their children in between the Disney movies. Yeah, looks good. People like to watch their surgery. Okay, done. No more herniation. Okay. Standby scope. That's 3 discs, folks. That's a long one. The next one is bilateral. It's two sides, same disc, L45, I think, right? Is that correct? Or is it L5S1? Okay. You want to take a look at the incisions, folks? I'll show you the incisions. Here they are, both of them. You guys see that, Sean?
Yes, we can.
Put pressure. I'll come answer questions, so go ahead and type them up. Thanks, everybody. Good job. By the way, these patients, some of them are they coming back tomorrow? I think I'll be around. We can maybe do a video, and we'll show you them if they agree. See how they're doing.
Thank you all for joining us for the post-op Q&A. We just wrapped up our second surgery of the day, and the largest one we're going to be doing today was a 3-level lumbar Duke laser disc repair. We're in the conference room now with Dr. Duke at the table. He's ready to answer some of your questions about neck and back pain. We have a question up right now. A viewer has asked, what diagnostic tests should my doctor perform before they fully commit to operating on me?
Okay, well, Dr. Dugmajian here. Thank you, Sean. Rolling through our surgical day and broadcasting everything, and I appreciate the question. I'm going to get to it in just a moment, so hold your horses. We've talked about a lot of things during this surgery. Just for those of you who have joined later, this patient is a Marine. He's a pretty tough guy. Marines are pretty tough, to be honest with you. I can verify that. But he's been living with chronic back pain like many people do, and he just got tired of it, and you know, he found us somehow. I don't know how he found Duke Spine Institute. Maybe the internet, maybe a friend who had treatment done here. Maybe he lived in the area. I honestly don't know. Do you know, Sean? No? All right. So we don't know if he's a local to Brevard County, the Space Coast of Florida, or if he came from out of town. I don't really keep track of that on every patient. But long story short, he's here because he's been suffering with chronic back pain, and he's had some shots and medicine and given it time, but nothing seems to work. And every time he does anything, his back pain gets aggravated, and it keeps him from enjoying life and doing things that he wants to do. And obviously this is a person who went through military in the United States, so he's made a lot of sacrifices in his life, and you know, I don't think he may not be active right now, but he's the kind of person who wants to, in his free time, enjoy life and be pain-free. And everybody's entitled to that, every human being alive. That's our philosophy at Duke Spine, is we don't believe people should have to live with back pain every day. So when you have back pain that lasts longer than 2 months, it's called chronic back pain. Anybody with chronic back pain has had their pain for more than 2 months. And we have people that we fix who have had back pain for 20 years. Every day, back pain. And it keeps them from doing things they want to do. Unfortunately, the problem is most people don't know Duke Spine Institute exists. They don't know that you can cure back pain. So that's what our job is to get the word out so everybody knows, so at least they have a choice if they want to get it fixed or not. So the question to me was, Dr. Dugmajian, what should my provider who's taking care of my back pain, maybe my surgeon, what test should they do before they, you know, commit to a surgical treatment? So there's 2 ways to answer your question, just so you're aware. There's the answer that is the quote-unquote standard answer, and then there's the answer that will get you the diagnosis as to what's wrong, so you can fix the patient properly. So I'll answer both. The standard answer is, before any kind of treatment on your back, it's really the standard of care to get an MRI, and if you can't get an MRI, then get a CAT scan. But saying that, the MRI is a very important test. But I'm going to tell you something. The MRI does not tell the doctor where pain comes from. It never does. There's a few exceptions to that rule, but they're less than 1%. So when would an MRI tell the doctor where your back pain's coming from? I'll give you the situations. Number 1, if you have a spinal fracture. Okay? If you have a spinal fracture of the vertebral body or what's called a fracture dislocation, then the doctor can pretty much tell where your pain's coming from based on the MRI. But those are extremely rare, and they're usually related to car accidents. The second way that an MRI will tell the doctor where the pain comes from is a tumor growing in your spine. And again, tumors are extremely rare. Very few people have them as the cause of their back pain. The third is an infection of the spine. You can see an infection with the MRI, and you can then know where the pain's coming from. Okay? So, fractures, tumors, infections. Those are the 3 times the MRI itself will tell the doctor where your pain's coming from. They literally represent less than 0.01% of back pain, chronic back pain. So what I'm trying to explain to you, very simply, is that an MRI does not tell anyone where back pain comes from, period. An MRI is not a test of pain. An MRI is a structural test. It sends magnetic waves into your body. It vibrates your atoms, especially your atoms start vibrating, and then the electrons orbiting the nucleus of those atoms start to shake and release energy. The energy released by those orbiting electrons is then picked up by a detector, which is the part of the MRI. That detector plate can tell what kind of atom is releasing the energy from its valence electrons based on the nuclear characteristics of the atom and other things around it, other elements around it. So water is white, usually, unless it's a T1 weighted image where it's dark. Fat has a certain characteristic look. Bone does, blood does, vessels do, discs do. So basically an MRI shows you structural things. It doesn't show you where the pain comes from. So what should your doctor do? The most important thing that I found is actually not the MRI, it's the physical exam. It's having the patient lift their shirt and point to their back to where they're having their pain come from. That to me is the most important diagnostic test. And it's really quite remarkable considering the technologies that we have these days in medicine, that the most reliable, most sensitive indicator of the cause of back pain, the specific cause, is the finger of the patient pointing on their back during a physical exam. And I can't tell you folks how many times I hear from people that come here, wow, you took your time to actually put your hands on my body and figure out where my pain's coming from. I've been to like other doctors, they don't even look at you. They just kind of walk in and say your MRI has this and that, we need to do surgery, without actually doing a physical exam. So I want to impress upon everyone, including my students, that the most important diagnostic test for figuring out where chronic back pain is coming from, same thing with the neck pain, thoracic pain, is the physical exam and having the patient point to the worst pain. That is the most reliable and important test. The second most important tests are a set of procedures called blocks. Blocks are basically taking a needle and in a syringe that has numbing medicine that numbs pain, and basically injecting things that you think based on where the patient's pointing, like the facet joints, the SI joint, the piriformis muscle, and injecting numbing medicine into those structures to rule in or rule out the source of back pain. Okay? So blocks are the second most important tool. You need an interventionalist who's really, really good at doing blocks. They have to be well trained and qualified to do it, and they can get a lot of important information from needles being put into the patient. So, number 1, physical exam. Number 2, blocks. Number 3, diagnostic imaging, such as MRI, CAT scan, maybe X-rays, and EMG nerve conduction studies for nerve pinching. There it is. Those are the 3 tools, tests that we use at Duke Spine. And the problem is that most people that are being evaluated around the world for back pain don't get number 1 or number 2. They just get number 3, which is the MRI. And so, of course, we have a lot of people in the world that don't get the right diagnosis because of it. Okay? So, when I told you earlier today, in the first surgery, Duke Spine Institute is very special for 2 reasons. Number 1, we can make the right diagnosis as to the cause of back pain. It's because of those tests, the physical exam, the blocks, and the diagnostic imaging. But the second reason why we're very special and different than anyone else is because we can actually cure back pain and neck pain with treatments that other people don't even know exist. Do we have another question? That was our last question. Enjoy your lunch, and hopefully you'll join us for the next surgery. It's a bilateral surgery on both sides for a patient with bilateral leg pain and weakness.